Hi, everyone. Good afternoon. Welcome, welcome. I'm Mary Beth Nelson, and I see a lot of familiar faces as always, which is great to see. We are proud to have a wellness talk today facilitated by Dr. Lee. Our topic this morning is colorectal cancer. March is Colorectal Cancer Awareness Month. These events are co-sponsored by the High Point Regional Health System, Cornerstone Healthcare, and Premier Imaging. And Sherry Nance is the director of Premier Imaging. I'm going to let her say a few warm, welcoming words, and we'll get the program started. Thank you for being here.
Hello. How are you all? I'm going to squeeze through here. I hope you enjoy your meal. We're so glad that you took the time out of your day to come and listen to this fabulous presentation. I just want to tell you a little bit about Premier Imaging. Please make sure that you get whatever you want off that table. We have the jar openers. Yes, look at Pam. Jar openers and the measuring spoons and some Eat Smart guides. We have all those things available for you. We also do Ma'am and Glam events for corporations. And we're coming out with some different packages, too, called Ma'am and a Movie, Ma'am and a Mani, Ma'am and a Makeover. These are different ones. So those are the kinds of packages that if your team doesn't have all the time in the world to come out, they can just come get their mammogram and leave with a package. So the Ma'am and Glams are something where we bring in the employer group in their private setting and kind of a team environment. There's refreshments, there's massage, there's makeovers, and there's your mammogram, your bone density screening, those types of things, just to make it more fun to come and have a mammogram. So, if any of you all are interested in anything like that, just feel free to call us anytime. And Mary Beth, where can they find your number? And my cards are here, so that might be where to start if you're interested. Okay. But again, thank you all for coming out today, and I'm going to turn it over to Pam.
Yes, we're thrilled to see you all here. Thank you so much for coming. This is an extremely important topic and very timely since it is Colorectal Cancer Month. I just wanted to, for some of you that I do see here are new, I just want to let you know that this is a monthly program. We're finalizing our plans for next month, and tentatively we think it's going to be about headaches. So if you think you might get a headache between now and then, or know someone who might, you might want to recommend to them that they consider coming. And we will, as always, post the information about the next Lunch and Learn on our website, probably within a week. That's cornerstonehealth.com. So I also wanted to, let you know why we do this. Our feeling is that it's extremely important because of all of the health information that's out there, particularly on the internet. And some of our dear friends like Dr. Oz and Oprah and other people, everybody seems to be a healthcare expert. And we feel very strongly that the healthcare experts are our doctors in our community. And therefore, we feel that it's important for us to give you the absolutely most timely, accurate, and well-educated information that we can about your health care. And also, so if you're hearing this information locally, you can actually go see that doctor if something that they tell you, is something you're concerned about with your own health or that of someone that you love and care for. So this is something that we're going to be continuing to do, and we are also always interested in any topics that, we try to pick timely topics that will, that we feel, that it's very important the information is out there, but also that in a lot of cases where we feel there's a lot of misinformation out there, and we want to make sure that we're giving you the best information we can, not only personally but to share with others, because we all talk to each other and do a lot of word of mouth, and it's important if you're spreading something that maybe it's based on reality. So we like to do that. Of course, if I'm talking about gossip, that's another thing. It doesn't. That's different. We're extremely pleased and honored to have Dr. Tri Lee of High Point Gastroenterology with us. Dr. Lee has been with Cornerstone for 4 years now, and he has quite an impressive background. He completed his undergraduate studies at Princeton University. He earned his medical degree at Dartmouth Medical School in New Hampshire. He served his internship and his residency in internal medicine at the University of Rochester in Rochester, New York. And then he completed a gastroenterology fellowship at the University of Virginia in Charlottesville, Virginia. Prior to joining Cornerstone, he was a clinical assistant professor of medicine in the Department of Gastroenterology and Hepatology at Penn State Milton S. Hershey Medical Center. So he comes to us with quite a vast experience and education, and we're very pleased that he found the time in his busy day to talk to us all today about colorectal cancer, how it's diagnosed, how we can prevent it, and how we treat it. So, Dr. Lee, thank you very much, sir.
Good afternoon, thank you. I do apologize. This is my very first talk ever since I left academics, so I'm a little bit rusty. Used to do this all the time, you know, but I'm very glad that my family and I moved down here. We enjoy it, and it's just a beautiful place and great place to be. Well, thank you. The structure of this talk is really very interactive. I'm going to show you about 10 slides of what I think are the basis of colorectal cancer screening, and then I'm here to answer any questions you have regarding colorectal cancer. This is the month for colorectal cancer awareness, and despite the fact that colorectal cancer is very prevalent, we're still a little behind in terms of screening regarding, you know, in perspective with breast cancers and other diseases. So let's talk about it. The background of this is that colon cancer is the second cancer killer in the United States, but it is also the most preventable types of cancer and is often curable by detecting early. In my career, most of the cancers that I have found are resectable and patients live a normal, healthy life afterward. So that's a key point I want you guys to take home. The lifetime risk for colon cancer is actually equal in both men and women. It's common after the age of 50, although it can happen at early ages. So therefore, that's why a current recommendation is that after the age of 50, average risk folks ought to go for colon cancer screening. Now, I'm going to detail why there's some certain group of population will need to be screened earlier and more aggressively. The risk of developing colorectal cancer also increases with age, and we know that based on multiple randomized control trials. Basically, what I tell most of my patients when they come into my office, I show them a little graph, is that basically it's kind of a flat line like this, and then after age of 50, kind of pick up. So that's really the reality of colon cancer. Now, for folks who could consider high risk, those are with a personal history of colon cancer, obviously, history of colon polyps in the past, family history. Family history is extremely important besides age. Some certain form of inherited diseases. Have anyone heard of familial adenopolyposis syndrome? People can have hundreds and hundreds of polyps in the colon, and by the age of 40, these folks will have 100% chance of having cancer, so they have to get the colon out. And then there are diseases which I used to deal with when I was in Penn State, Crohn's disease, ulcerative colitis, inflammatory process of the colon predispose you to colon cancer at an early age. This is very important. I wanted you, the take-home message here is that most of the time you don't have any symptoms. People tell me, well, doctor, I don't have any rectal bleeding, I'm not having pain, I'm not losing weight, so I'm not having colon cancer, so I don't need to be screened for. That is completely wrong. I have to say, when I've been in High Point for 3.5 years or 4 years, and I've diagnosed about 20 cases of colon cancer. I have to say 80% of those folks have no symptoms. The rest, rectal bleeding here and there, but I have to say majority of them have no symptoms at all. That's why we need to do screening. Obviously, the common symptoms are abdominal pain, you have blood, visible blood, or microscopic blood, and change in bowel habit. Somebody who has normal bowel habit, and certainly pencil-thin stool, diarrhea, also can be an indication of colon cancer. Screening for polyps. this is the reason why we need to screen. Polyps, what are they? Well, those are the little growth in the colon. They are benign, however. Yet, if you leave them long enough, over 4 or 5 years length, they can become colon cancer. So therefore, the current recommendation is based on the fact that we need to screen early, we need to detect these polyps, remove them before they become cancer. More than 7, this is a very important message also here, is that 7 to 90% of colorectal cancer can be avoided through early detection and removed of precancerous polyps. So if you can see that's how effective colon cancer can be. So the ACG guideline, the entire talk here, I take it from the ACG website and their information. I'm going to go slowly, step by step, for each of the recommendation. Currently, the ACG, which is the American Society of Gastroenterology, recommended that for folks who have average risk. Now, average risk means that you don't have family history of colon cancer, there's no family history of colon polyps, no ulcerative colitis more than 8 years, or Crohn's colitis for more than 8 years, you ought to undergo colonoscopy as a screening technique starting at the age of 50. That's for average risk. Very important information just came out recently within the last 2 to 3 years. African American folks ought to be screened earlier, not 50. If you consider yourself average risk, but you're African American, ought to be 45. The reason for that, and I will go in detail a little bit, is that colon cancer is more prevalent in the African American population. They can occur more earlier, and also the fact that they are not within reach of a flexible sigmoidoscopy, which is a shorter scope version. It is all tend to be more proximally, so you have to undergo colonoscopy in order to prevent colon cancer. That's the preferred colorectal cancer prevention method. Now, what about the preferred method for colorectal cancer detection? There's a key difference here, detection and prevention. Detection test is designed to detect cancer when it's already happened. So really, what you really want is colon cancer prevention. You want to detect polyps before it becomes cancer. Does that make sense? So the detection, the way to detect cancer now, the recommendation, which we have in all our Cornerstone clinics now, is the FIT test, the immunochemical testing. It doesn't mean that you have a positive stat that you have colon cancer, okay? So please don't be so worried and come home, oh my God, I have colon cancer. No, the screening test is designed so that it catches everything. It has sensitivity, although it lacks the specificity. That means it can pick up anything. However, it is a test that you can use if you're not willing to undergo colon cancer screening. And it's basically a stool test. We send you home with a card, and you send it back to us, and we develop it. And if it's positive, then you ought to go for colonoscopy. Okay. Now, this slide is basically the alternative prevention methods besides colonoscopy. If you're not willing to go for colonoscopy, remember I said there's another way of doing shorter scope version, the flexible sigmoidoscopy. The difference between colonoscopy and flexible sigmoidoscopy is that the flexible sigmoidoscopy, you don't have to undergo the preparation process. You don't have to drink that gallons or whatever your physician decides to do. However, you still have to get preparation somewhat. You have to get an enema to clean your colon out. The disadvantage here, and this is how I interpret flexible sigmoidoscopy, is that doing flexible sigmoidoscopy for colon cancer screening is almost like doing a one breast mammogram. Because you are in reach to a third of the colon. 2/3 of it you don't know. But it's still recommended as an alternative for folks who don't want to go undergo colonoscopy. And the frequency is about every 5 years. Okay, so if you have one today and it's normal exam, you should have another one in 5 years. The alternative detection test, you can do a CT scan, as a matter of fact. Within the last decade, we have something called CT colography or CT colonography. It is, right now, is an alternative, and occasionally I use this for folks who have a lot of comorbidities, significant lungs disease, heart disease, and that they cannot undergo sedation or difficulty with prepping. I use this as a way. Now, keep in mind, though, CT colography doesn't mean you don't go through prep. The prep is pretty much the same, okay? So you still have to go through prep. So don't think that you're not going to get prep on this, because the radiologist is not going to be able to see anything if you don't get the prep, okay? And then the alternative, which you don't need to know about, is a fecal DNA test, and I don't think there's any practice will carry that yet because it's so expensive. So the new guideline, starting in 2009, focused the different main focuses on African American population. And based on this data that we have, colonoscopy is the preferred method, not flexible sigmoidoscopy. Remember, because most colon cancer in this population is in a proximal colon, so you need the entire length of the colon looked. Begin at a younger age, because, as you mentioned here, is that high incidence of colorectal cancer in this population and more proximal disease. So that's it for the basic information that I have, and then I'm going to stop here, and you guys can ask me any question about colon cancer screening. Okay? Yes?
Is it just heredity, or are there certain foods or lifestyle choices that you can make it less likely that you'll have?
Sure, sure. That's an excellent question, and we don't yet know the definite answer. There is certainly hereditary. Remember, I mentioned there's certain hereditary diseases that can predispose you to 100% risk of cancer. So if you don't get your colon out, you will have colon cancer. Those are familial adenopolyposis, FAP. These folks start in the age of 14, start having polyps already. And by the age of 20 or 21, 25, if you do a colonoscopy, you have hundreds and hundreds of these polyps. And so what happened here is that you have to have your colon removed by a surgeon, or else you will have cancer. That's hereditary on the extreme end. And then a lot of time here, about 25%, excuse me, more than that, it's about 75% of the time is sporadic. You have no idea. It happens, and we think most of this is developed from polyps. Those are the benign growth that I mentioned about. And the reason why, people ask me this all the time, why do we have polyps and how can we prevent polyps? We don't know yet. We're working on it. We think there's certain genetic abnormalities, certain environmental factors, but there's so many variables going to this that we yet pinpoint one thing that can tell you, all right, you go home, stop eating this or doing that. Now, there are some evidence that eating a low-fat diet, high calcium, taking folic acid, taking aspirin, using drug like allopurinol for gout and whatnot. There's some evidence that has been shown to reduction in colon cancer, but at this point, the data is not strong enough to have any organization support it wholeheartedly. So I would just say eat healthy and screen for colon cancer, whatever you can. That's all you can do. Yeah.
If it's so preventable, why do people not GI colonoscopy?
Yeah. Well, that's a great question. I'm still trying to figure that out. I guess because, from my perspective, I think that, and tell me if I'm wrong here, because this is my perspective, and as a physician, not as a patient. I have heard a lot of my patients, they come in, they give me that look, you're not that sexy cardiologist, you're that colonoscopist, like who wants, colonoscopy, And their friends said, oh God, the prep is horrible. Is that what you've been hearing? So I keep hearing this, and I said, look, I don't disagree with the fact that this prep is not as delicious as your meal last time you ate, okay? If it is, that doctor's doing something wrong, because it can't be. I mean, it's medicine, okay? But most of my patients, this is just a one-person perspective, most of my patients, the prep that we have at Cornerstone they tolerate very well. Now, there are a lot of PrEP types out there. Used to be the pills. Guess what? The pill's not on the market anymore because it has kidney problem. People have phosphate nephropathy. So that's been out of market. But remember, even when the pill was available, you don't take one pill. There's 30-some pills in there. Okay, so it's not, people say, oh my God, I didn't know that. You know, not one pill? No. So quantity is never, you cannot get away from that. So there's different preparations, and now with the new generation of PrEPs available, instead of the 4-gallon quantity that you used to have, now they reduced it down to half now. So that it's basically it's a half gallon or 2 liters roughly. That's the PrEP. And then with our group, I can't say for everybody in the country, but with our groups, we use combination of Gatorade sport drink and Miralax mixed. Now, I compare my own previous experience at Penn State. We didn't use this Miralax PrEP. We used the typical, either the 4-gallon type or the half-gallon type. And patient here seemed to respond a little better. Now, it's not a head-to-head comparison, so I can't be for sure, but it seemed to me that they liked this PrEP a little better. So, and the key thing here too, a lot of my patients, particularly the one that, you know, give the impression that it's going to be a horrible PrEP, and afterward they said it's easier than they thought. So that's usually what I get. Am I speaking just from, am I completely off base here?
I think most of it comes from the fear of the unknown. If you don't
True.
know what you're getting
Mm-hmm.
into, then you don't want to do it, especially when you hear horror stories from other people.
Yes, yes.
But after you sit down and you talk to someone,
Mm-hmm.
or you look on the internet and you find out, then it's like, oh, okay, well, this might not be so bad after all.
Right, right. And that's,
You don't remember it at all. I mean,
no.
it seems kind of you're going to do what with what? But the reality is you don't remember a thing.
Exactly. Right, right. It is. Yeah, it is. Yeah. Yeah. Right, right, right. Well, the thing that I think the point that you brought is very, very important. There's another thing though. People always remember the horrible story. They don't remember the good stories. And I have a few patients come and said, you know what, my friend had a perforation or had a bag afterward. The reality is, yes, that's perforation. And if you're a colonoscopist and you have yet ever got a perforation, you either just got out of school because you haven't done enough. It's almost like if you haven't ridden the horse long enough, you're not going to fall off, right? So it's known. It's built into it. You can get away from it. The only way, so the rate right now for perforation is about 1 out of 5,000 cases. So it's pretty low. And usually that happens to folks who have a lot of medical problems already and more of advanced age or difficulty colon from surgery and whatnot. So
How would you repair that if that did happen?
surgery. Now there's a spectrum of severity. Occasionally you can just bowel rest, IV antibiotic, follow up with CT scan, make sure there's resolution symptoms-wise, and that's all you need to do. This is when you nicked it to the tiny little bit of, but then if you have a big hole, and then the surgeon have to open it up and sew it back together. Yeah, yeah, yep.
How much of, I guess, like a predetermined are conditions like acid reflux and things like that related to
So your question is, there's any association between reflux and colon cancer? There's none, not that I know of. Yep.
I gotta ask you. If you do end up with colon cancer, like a late-stage colon cancer, what kind of cancer is it? Is it a slow, painful death, or is it you're out of here quick? I mean, what happens with something like that? Because it seems to me, as a PR person, that if you could scare people more about how terrible cancer
Yeah.
the colon is,
Yeah.
they might be more likely to say, look, this is a pain to have this done, but it's a lot better than dying of this horrible disease.
Right.
I mean, is it really bad as you know, as deaths go?
Well, to be the most accurate about it's comparatively, you all heard of pancreatic cancer, right? This is a lot slower than pancreatic cancer. We're not talking about 6 months survival. We're talking about a little bit maybe within a year or so, but that's all depend on the stage of the colon cancer. Now, if you leave colon cancer long enough and not doing anything about it, the worst death probably would be a bowel obstruction death. It's very painful. You have basically your bowels is completely shut off. You cannot get anything through. You'll be in severe excruciating pain. So cases where I encounter where the person is advanced age, too many medical problems, you really can't undergo surgery, can't handle chemotherapy or radiation, whatnot. So the way that what the surgeon would do is that they come in and make a loop, colostomy, a diverting loop, so the stool or whatnot can go past the obstruction. So the patient will eventually perish, but in a more peaceful way. But it all depends on the stage. Luckily, is that most of the time when we detect colon cancer is at stage where all you need is a resection. We call it stage 2 or less. Now, stage 3 is when you start having lymph node involvement. That's when usually afterwards you have to undergo chemotherapy, adjuvant therapy. And stage 4 is when you have metastatic disease. Particularly the liver, that's when it usually goes to.
Dr. Lee, do you have any recommendations on testing for people who have a parent die from an early age from colon cancer?
Sure, that's excellent questions, and I'm going to answer this slowly, and then if I go too fast, let me. I want you guys to remember this, okay? If you have a parent with colon cancer, this is first-degree relative, parent, sibling, or your own children, with any of this first-degree relative with colon cancer before the age of 60, you ought to have colon cancer screening at 10 years earlier than the time of that colon cancer detected, or at the age of 40, whatever comes first. Does that make sense? Okay. The other scenario, if colon cancer in first-degree relatives beyond the age of 60, a lot of time I have to say when I ask my patient, how old was it when your parents had colon cancer, they can't really tell you. So it's sort of more of an academic answer, whatever. But if say you know for sure that your parents have colon cancer in their 80s or 90s, then I think right now it's safe to start screening at the age of 40. You don't have to do that 10 years things. And then if you have two relatives, second-degree relatives, okay, grandparents, uncles and aunts, two of them have colon cancer, you also need to be screened at age 40 as well. Okay? And then there are another groups where you can go into it is that when you have ulcerative colitis, Crohn's disease of the colon, if you have beyond 8 years of disease, and usually when you have extensive disease that's involved more than 2/3 of the colon, then you ought to be screened 1 to 2 years, every 1 to 2 years, start after 8 years of disease. So.
What about the appearance of polyps? What if you have to the father that every time he has a colonoscopy,
Mm-hmm.
he has polyps? Would that change my schedule as a person with
Yes, it would. And what I tell my patient when I find a polyp is that I can't tell you yet when you need to come back. I usually give them 3 to 10 years. That's all I can do. I have to wait until the biopsy to come back. Based on the biopsy result, based on the size of the polyp, and based on how I feel that polyp was removed, and also, very important here, and you guys need all to understand, is that on the prep quality too. I mean, if your prep is, I consider fair, I'm not going to give you an A grade and tell you to come back in 10 years. That's really unsafe. So, but the unfortunate thing about that is very subjective, you see. I can say you come back in a year because I'm conservative, but another endoscopist say, yeah, I come back in 5 years. you can't fault anybody for what exact time would be, but I have to say that the number one thing that patient can do good for themselves is that take this prep. I know it's horrible, it's not as great, just take it and clean it out so that you don't need, you have to come back soon.
I know that, like, already here, as far as like diet pills,
Mhm.
bowel cleansing, that they
Right.
do different things.
Yeah.
What are your thoughts on that?
Boy, bowel cleansing. Whew. There's no data to support that at all, okay? There's zero. No, the folks who do bowel cleansing are probably going to say otherwise. But I can tell you, scientific information up until recently, there's none to support this, either prevention or slowdown or whatever health of your colon. So if you, don't waste your money, please, on that. I mean, I'm sorry if it's offended anybody, but there's no scientific data to support that. It can cause perforation. I have seen I wasn't involved in the case, but I heard a person who underwent bowel cleansing and had a perforation. I mean, you insert a tube in a little bit, and then you squirt water. That's what they do, hydraulic, some sort of. I'm not really involved in that, but I mean, yeah. I mean, when I go home visit my parents in Pennsylvania, I drive 95, past Richmond. There's always that billboard right near. I don't know, you guys, like right near the University of Richmond. Colon cleansing it's always there. It's been there for 10 years. Never been taken off. Yeah. Yeah. But no, please. There's no data at all that's been undergone trials or clinical trials, anything.
With all the prep that there are out there today,
Yeah.
what's on the horizon for it not being so nasty?
Nothing that I know. I remember I mentioned the one, the two gallons prep. There's one piece of information that I want to relate to you guys, that there are data regarding, not so much to answer your question, but sort of as associated factors, that there's a lot of evidence showing that you split the prep into, say for example, you have your colonoscopy in the morning tomorrow, okay? In the past, folks tend to give you all at once to drink, maybe 5 o'clock the day before, and then the rest of the day is enjoy the toilet, right? But now, to improve the quality of the prep and perhaps to make the patient don't feel like they have to take everything down at once, we split them. So same amount, it's just that we split them. Say 5 o'clock, you take half of that amount, and then at midnight, you have to take another half. And it's good for two reasons. One, easy for you guys. Two, is that the quality of the prep is better. So we call that split prep dosing. And it's actually currently become a recommendation from the American Gastroenterological Society to do that.
Is it being used now? Is that being used now?
Yes. And for my prep, I can speak for I don't use the gallon, the half-gallon prep. Occasionally I do. The reason for it, I think, is the price-wise. I don't like to use the name, but we call it's called movie prep. That's the half-gallon prep. I think if you spend about $60 for the prep, and we have coupons, so it may take it down to 40s. But the prep that we use with Gatorade and Miralax mix, that's the cost of with the cost of Gatorade and Miralax. I think it's all come out to be $20 the most. So it's cheaper. What I have is that sort of it's a split dose as well, because unfortunately you have to drink that max citrate bottle, that little tiny little bottle. It doesn't taste good, but you do take one the day before and one 3 or 4 hours prior to the exam. Now, one thing I can tell most of my patients, if you want to make it a little easier for yourself, is chill the prep in the refrigerator and just drink it from the straw. So, thank you.
Doesn't all that make you dehydrated though?
No, actually, and that's an excellent question. I want to answer that. In the past, a certain preps has electrolyte shifting, okay? And you should be worried if you have CHF, heart failure, kidney disease, people, elderly folks, right? Summer, you do this prep during the summer. But now, even with the without prep, the Miralax prep and the Gatorade mix, and then the movie prep, they are designed to be electrolyte. That means that there's not much shifting at all. So you shouldn't worry. So I use this prep pretty readily in patients with kidney disease. So I'm not really concerned about that. But keep in mind, though, fleet enema, fleet phosphate soda, phosphate, those can cause electrolyte shift and electrolyte absorption. So you got to be careful with folks with kidney disease.
Dr. Lee, on the prevention end, what are the latest studies on the effects of diet and the prevention of colon cancer?
That is still debatable. Low-fat diet is recommended, although it's been recommended, although it's conflicting data. But in general, we recommend eat low-fat, red meats and whatnot. High fiber diet is advantageous. But again, the data, the caliber of the data is not really strong. So, but again, you know, you're talking about basically the basic recommendation is eating healthy, basically. So really.
Any type of natural dietary, anything?
None that I know of.
Natural stuff?
None that I know of. No.
I
Yeah.
want to know too, how long does it take, or what's my time limit on if I have an obstruction?
Uh-huh.
What are like my symptoms, and how long do I have?
Yeah.
I know it can lead to death.
Well, it really depends. But if you have an obstruction and you're not doing anything about this, obviously the first symptom you will develop will be pain and bleeding most likely, because if the mass is that big to cause obstruction, you probably will see gross blood. And of course, a lot of people write it off as, oh, that's just my hemorrhoids. You shouldn't, after the age of 50 and you have rectal bleeding, be careful. It may not be hemorrhoids. But again, I agree, most of the times are hemorrhoids. Pain, weight loss, and pain particularly after eating or close to the time after eating, because that's where the food starts go down and it hit the obstruction and it just can't go anywhere, so that you have pain. So, yes?
Well, my question has to do with hereditary
Yeah.
diseases. You're talking about if a first-degree family member had colon cancer. What about stomach cancer?
How to screen for stomach cancer?
No, would they be predisposed maybe for early screening? Would that be
For colon cancer? Not, actually, if you have one of those syndrome, the FAP syndrome I mentioned earlier, not only can cause cancer of the colon, but can cause cancer of the stomach and proximal small intestine. So if you have that syndrome, you have to, even if your colon is removed and you're free of colon cancer per se, you still have risk for cancer in the upper tract. Then you get screening for the upper tract. Yes.
My son-in-law's father died at an early age with stomach cancer.
Right.
He's just turned 41.
Right.
I was thinking he may need to live.
Well,
Can we not get screened?
well, what he had may be just a sporadic stomach cancer, but not so much a stomach cancer related to a syndrome with colon cancer as well. In that case, not necessarily he needs to be screened earlier. Does that make sense?
He is mixed race.
Okay.
So I don't know how that sort of
Yeah.
medications.
Yeah, yeah. So,
My question was about the ulcerative colitis.
Yes.
And Crohn's.
mm-hmm.
Does that also have anything to do with IBS? Like, is that one of the ones you want to screen for?
No, IBS is not a risk factor for colon cancer, nor is something that make you go for colon cancers earlier. Although I have to say IBS symptoms are so non-specific. So sometimes you go into your doctor's office, you tell them your symptoms, and the doctor, his duty is to make sure you don't have colon cancer because you can't tell initially, right? And IBS is the diagnosis of exclusion. So you have to rule out the serious problems before you can say you have IBS. But IBS itself, no, it's not a risk factor. Me? I have not. Yep. So.
Is the FIT test that you were describing the hemoccult test?
Mm-hmm, mm-hmm.
The same thing?
Yes. But it's a different way of developing it, and it's the old hemoccult test in the office, or the one that the cards that you send home is actually less specific. So this you kind of eliminate. Remember in the past you said you can't eat red meat and da 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 da. Now actually it eliminates some of those fringes. But it's so. All right. Any other questions?
Well, I think, I don't know about you guys, but I think I learned quite a bit this afternoon, and I very much appreciate Dr. Lee preparing his presentation and anticipating questions that we would have.
Thank you. And I feel like we could go on for a couple more hours and get down to every single part of the digestive tract, and maybe we'll invite you back to talk about some other topics. But for now, I just want to thank you all so very much for coming. We do have on our homepage of our Cornerstone, www.cornerstonehealth website, some real good fact sheets similar to what we've had handed out, that if, depending on where you work, you might want to print them out and post them for your fellow employees and colleagues, because it does have a lot of this very important information. And I don't know about you, but if there's a chance to stop someone from getting cancer by 75 to 90%, I don't care who I'm talking to and how offensive I may be. And trust me, obviously I don't mind about being offensive, but I really do feel like we have an opportunity here to be disciples of this message and let folks know that, and as you said, it doesn't taste that bad. And I think people giggle about it, and I think people, like you said, they get embarrassed. I think it's like everything. And, I don't think anything could be more, nothing is as embarrassing, as tragic as getting colon cancer would be. So I think it's just, let's put it in perspective, folks. Let's put on our big girl panties and get to work. Well, and yeah, then you're gone. Yeah, exactly. I mean, everything's out there. There's no stirrups involved. Maybe that could be our bumper sticker. Get a colonoscopy. There's no stirrups. That is true, isn't it? Yeah. Well, I think that, when it comes down to life or death. I mean, I'm sure if you had that one message, it would be, for goodness sake, you don't want to get colon cancer. But it's nice to know if you do. We have doctors like Dr. Lee that have offices here in this very building and downtown in the medical center. And all you have to do, if you have any questions or concerns about family members or other folks, is give them a call. And we've got a professional expert right here in our backyard. So we're very blessed to have that in our community, and we appreciate you very much coming here to learn about all of this health information. Thanks so much. Have a great afternoon. We'll see you again soon.